So welcome everyone to the 8th annual Stanley Noort lecture. If you can bring your wine and food in, that would be great. Have a little seat. We're trying it differently this year. Normally we have it outside there and in the auditorium, but this is a nice space, so I hope you're enjoying it. I'm Nancy Young. I am the Director of Development with Health Advancement. I work exclusively with the Neurology Department, and I work under the Vice Chancellor of Advancement and the UCI Foundation. So yes, we are the fundraising arm, and we're hosting this this evening for the Department of Neurology. And I wanted just to, before we welcome our speaker, our distinguished speaker, and the chair of our department, I just wanted to say a few words about private giving to UCI Neurology. Support from the community comes in the form of private gifts, and that really gives an opportunity for individuals to give towards our physicians and our scientists, and gives them the freedom to of unrestricted funds to find the cures and treatments through research, and really to make a real difference in lives for our patients. So I just wanted to say that I'm really proud that this year the Neurology Department raised in grants and donations and pledges a record just shy of $2.5 million. So that's great. That's mostly the work of our doctors. And these gifts are supporting leading-edge research. Some of the examples are the breakthrough stem cell research in ALS that some of you may have heard about. Dr. Goyal is the PI in that, and I know Dr. Mozavar supports that. We've had some great outcomes in glucosamine research in multiple sclerosis, and Dr. Demetrio and Dr. Courtney are involved in that research. Identifying biomarkers in Parkinson's, and Dr. Philippe and I think Dr. Fedorov are involved in those research. So that's just a few. We have fellowships in stroke and fellowships in neurocritical care, and these are all from patients, which is just phenomenal. This morning I just had a talk with one of our patients who has agreed to give a $500,000 gift based on the care that he got here for him and his wife. And that $500,000 is going to Parkinson's research, brain tumor research, and kidney disease research. So these are wonderful outcomes, and it's really the work of our physicians and our scientists here that really, I think, everyone deserves applause. So I just wanted to take a minute also to acknowledge the ALS and the Neuromuscular Center, who earlier in this year, and maybe Dr. Mozavar will talk about it some more, reached a couple milestones. It was the 10-year anniversary of the founding, and they also received the National ALS Society's Center for Excellence designation. So that's just wonderful milestones, and we're hoping to maybe launch a mini campaign to make sure the center is well funded for the next 10 years. So we are doing fundraising. If you want to give a donation, you can come talk to me, or we're also taking donations at the front desk there, and tonight only, for a $100 contribution, we have a set of note cards featuring Dr. Starr's work, and Dr. Starr is the founder of the Neurology Department and a wonderful watercolorist. You want to say, just wave your hands. It's beautiful. If you go to the front table, you will see his artwork. It's beautiful. So Arnie is kind of like the father of neurology, and the mother of neurology is really June Van de Noort. So I wanted to acknowledge June. Yay! And Mrs. Van de Noort, is delightful, and she gives in so many ways to the Neurology Department and the nursing school, and she gives moral support, and her family are here, so we wanted to welcome her and to thank her for everything she does for the university. And so without further ado, I'm going to introduce you, if you don't already know him, Dr. Tassin Mozavar, who's the chair of the Neurology Department. Thank you.
Thank you, Nancy. I had the pleasure and honor of working with Stan Van de Noort when I first arrived at UCI in 2000, and I was lucky that my clinic was right next door to Stan's clinic, and I learned a lot from Stan. He was the ultimate clinician, the ultimate gentleman on that, and I'm glad that Neurology about 8 years ago decided to honor him with this annual lecture in his name. Stan obviously had a lot of influence on other folks as well. He was the dean. He was recruited from Cleveland. He came in '68, became the dean, and also helped create the Department of Neurology in the early '70s with Arnie Starr as the founding chair of neurology on that. He also tried very hard to get a hospital on the UCI campus, something that it cost him political capital and ended up resigning because of that. But now, with at least with the efforts of Dr. Fedorov, we may be getting a hospital on the campus in the next 3 or 4 years, which is going to be a wonderful addition to the thing. Stan, as at least I was told by both Stan and Michael Swash, was also responsible for our guest today to go into neurology. My understanding, at least the version of the story that I heard, was that Dr. Griggs was a resident in medicine at Case Western when he met Dr. Van Noort and Michael Swash, who recognized his brilliance and recognized his potential, and I encouraged him to go into neurology. But you can tell us the real story when you come on the podium, Birch, on that. So Dr. Griggs, or Birch as we know him in the neuromuscular community, has been a wonderful mentor. He's really a wonderful role model for folks who are going into academic neurology because he's done it all, so to say. He trained in medicine at Case Western, then went to NIH, to the medical neurology branch, did his neurology training there, and then went to Rochester, where he finished the year as a chief resident in medicine, but also chief resident in neurology, and stayed on faculty there. And slowly moved up the ranks to become a full professor and then a chair of neurology. And he remained a chair for a very long time. He recently stepped down as a chair about 8 or 9 years ago. But in the process, built a wonderful program at neurology in Rochester. He recruited a number of very bright individuals who really became leaders in the field. I've known Birch through his work in muscular dystrophies and neuromuscular. When I got to WashU in '91, they had recently finished the CIDD study, which was a natural history study of Duchenne muscular dystrophy. But Birch also did wonderful and seminal work on periodic paralyses, myotonic dystrophies, etc. I feel that his biggest contribution was really establishing the field of experimental neurotherapeutics, which he's going to talk about today. And I believe Dr. Fedorov had something to do with it as well. He was recruited to Rochester for that reason as well. Birch also was the president of the American Academy of Neurology, and he's been involved with the Association of University Professors of Neurology. And then since he stepped down as the chair, he's been sort of working around the world in promoting neuromuscular health. He has collaborations in China, he has collaborations at the University of Florida, and spends a few months in England as part of the collaboration as well. I was really delighted that Dr. Griggs agreed to come here as the Van Noort lecturer, and I would love to hear what he has to say about the field, but it's just an honor to host you, Birch. Thank you.
So thank you so much, Dr. Mosavar. And thank you to all my friends who've come here. One of the things that's impressive about Irvine and this school is that, when people from Rochester get older, they can't wait to leave. I see so many old friends here, they just won't go away, I guess. They're here, and it's just wonderful. I think this place has been a magnet for some outstanding people. Great to see Arnold Starr here. Great to see Bob Chilcote, who was he was a pediatric resident in Rochester. He's out here. I mean, the number of people, Bill Preston, that are just old friends here. It's just a great pleasure. So I'm so pleased and honored to be invited to give this lecture for really two great reasons. One is that this is a wonderful place, and under the leadership of Stan Van Noort, it became a widely recognized place, and then moved up under subsequent leaders, and particularly under Steve Small, who did who doubled the size of the department, brought real distinction, and then most recently, Tassin has taken over, and he's in his interim position, is doing really terrific things. And of course, I take great pride in the fact that Howard Fedorov has simply been transformative in his influence on this place. And so Howard was someone I recruited to Rochester. He was part of our program in Spinal Therapeutics. That's the commercial I'll be giving later in the program. Actually, one of the audiences, which was a former trainee, and the brother of a former trainee is actually in the audience, Dr. Schwid. So that's one reason. This is such a great place, so it's a real honor to be here. The other thing is that, as Tassin mentioned, I knew Stan Vandenort exceedingly well. In fact, I think he was my first teacher in neurology. And when I was a medical resident at Case Western Reserve, I almost hesitate to tell you how long ago it was, but since I started internship when I was a teenager, you can understand that when I was a medical resident in Cleveland, this was in I think 1965 that I worked with Stan Vandenort for 2 months on the neurology service. I actually did 4 months of neurology. Joe Foley was the chief. Many of you will know that name. Everybody was supposed to do 2 months of neurology and 2 months of psychiatry, and neurology was shorthanded, so they said, could I stay? And so I was perfectly happy to do that. But I had 2 months with Stan Vandenort, and I asked him, could he teach me EEG? And so I worked with him, read EEGs, read all the EEGs for 2 months, and I don't want to offend any of the epileptologists here, but that is absolutely, I was a medical resident. This is the only EEG training I ever had. So that it served me in very good stead, got me through various boards and other things, and Stan was a wonderful teacher. He also had, those of you who know him knew he had a marvelous, I was talking to somebody who does bumper stickers who was telling me some of the things, some of the jokes he shared with Stan Vandenort. He had the most outrageous and irreverent sense of humor, and he was just absolutely, I'm not sure if he could survive in today's world as an academic, because he just was so irreverent, but he had such a wonderful way of looking at patients, a consummate clinician. And what a great person to start me off in my interest in neurology. So that makes it just, this is so special to be here in this lectureship in his honor. So this is such a great place. I was pleased to meet so many people today. You know, you have outstanding people. Mark Mapstone is one of the people I mentioned. He's terrific. Tali Barham, Claudia Kawas. I hesitate to mention all these. There's so many wonderful people here. That makes this special. So turning to my topic today, this is a fairly broad audience, and so I'm not going to talk too much about details of science, but I want to give you my perspective on advances and challenges in developing treatments for neuromuscular disease, because I think we're making progress. In fact, I think you could almost argue that stroke started making progress, and I think they've made great progress. But I think neuromuscular may be leading the way and helping us to think about how we're going to treat about other things in neurology. And most of the problems and other issues that we see in neuromuscular disease, I think, are going to turn out to be problems and issues in other fields. So I just want to talk about my field. I'm particularly interested in muscle, but I'm going to give a quick overview of all of neuromuscular disease, since most people that do muscle do the rest of neuromuscular disease too. So I want to then turn to my conflicts of interest. I actually sometimes think I should give an entire hour's talk about conflicts of interest, because they are really, really interesting and important, and some people just gloss over them. I'm going to have to tell you just a little bit about mine, because I just want to point out the fact that I'm going to tell you about the T32. I don't think my pointer's doing what it's supposed to do. I don't know if it's not doing anything, but you'll see the T32 training grant there. That means I try to get young neurologists, and I've already targeted one in the audience, to come do an experiment. The one who's going to UCSF, you're finishing a residency tomorrow. I've already said you got to come to Rochester to train in experimental therapeutics. So that's one big obvious conflict of interest, trying to move all your young people to work with me. The other one I need to mention to you is the fact that American Brain Foundation, next to the bottom line, American Brain Foundation has funded through various partnerships with the Academy of Neurology, funded almost 250 young people. This is the American Brain Foundation. For those of you who are neurologists, it's the foundation of the American Academy of Neurology. And so I hope you're thinking about supporting your foundation. We have 250 young people we've given 2 to 3 year training fellowships, of which 85% of those have gone on to NIH funding. Their track record, and we had the number of applicants has gone up to several hundred every year, and we are funding at about the rate that NIH does. It's highly competitive. We need more fellowships. So that I'm pushing the American Brain Foundation. Everything I'm saying is wanting people to give money to support the careers of young people. So there are other things I could say about that, but that's enough on my conflicts of interest now. This is sort of my outline for what I'm talking about. And I'm going to start off with talking about FDA-approved therapies. First in 2005, what the state was. Then I'm going to talk about where we are with new and better treatments. I'm going to talk about some of the challenges, and you're aware of them. But I think neuromuscular disease illustrates the problem of some of the challenges of the new approved treatments. And then because there are a lot of diseases that have no treatments yet or no FDA-approved treatments, I'm going to deal with those very quickly. So I want to turn now to the situation in 2005. There were no approved treatments for muscle diseases. That changed in 2006. We got one. This is for muscle disease. Now, as I'll point out, there are some treatments now in 2018 for each category of neuromuscular disease. Neuromuscular junction, of course, I should point out that there was, in fact, under the neuromuscular junction, Mestinon was approved in 55. It didn't keep, there are still most of the myasthenics, lots of myasthenics ended up on intensive care units. But it was a treatment. More recently, the most recent one is eculizumab, a monoclonal antibody. That's it. There are lots of other good treatments for myasthenia, but they're not FDA approved. Anterior horn cell, riluzole, approved in 1995, now available in generics. Edavirone is one that I have no experience with. Nobody in Rochester has used it. Tassine, have you used it? Some. Proving to be very expensive, marginal. It's incredible that it was improved. No studies in this country approved in Japan, but because this is such a major challenge that somehow this drug got approved, where most of us are stunned by the fact that the FDA approved it. Then in the anterior horn cell field, the really exciting one is that there's now an approved treatment for spinal muscular atrophy. It's one of the worst diseases of mankind. I'm going to talk more about that because what we know about that is just sort of illustrative of where I think much of the rest of neuromuscular disease is going, where much of the rest of neurology is going to head in terms of thinking about the strategies for treating it. But it's sort of a prototype for what we're looking at. Peripheral nerve, there are also treatments. Now this is really interesting. I thought that IVIG was, since it's in wide use for chronic inflammatory polyneuropathy and for Guillain-Barré syndrome, I had assumed, I didn't actually realize this until I was making the slides up for this, IVIG is not approved or not FDA approved. So I also found that there is a form of IVIG that is now just recently, within the past few months, gotten orphan drug approval by the FDA, orphan drug designation, not approval, orphan drug designation. What this means is when I come back to talk about some of the problems with orphan drug pricing, now that's one of the later things I'm going to talk about, that this drug, the new drug that's got orphan product designation, will put these other things that are used off-label currently off the market. And so we'll have the same problem for IVIG. Now, the other thing that I hadn't really thought about that probably many of you already know is that plasma exchange, not regulated by the FDA, it's not FDA regulated. It's a procedure, it's like devices have a different, they don't have to provide evidence of efficacy to get approved. So plasma exchange for the Guillain-Barré syndrome, for CIDP, dramatically effective, but not an FDA-approved treatment. I should say, for one of the reasons for mentioning being so pointed about FDA treatment is if I talk in CME anywhere, any grand rounds anywhere, they always want to give CME to the people. You're not allowed to talk about any treatment that's used off-label without making it very clear that this is not an FDA-approved treatment. It's a remarkable thing because just because a drug isn't FDA approved doesn't necessarily mean that it might not have some benefits. So many of the treatments that are in wide use in neurology have never been approved. This then poses the same problem that I'll come back to in terms of if somebody gets an orphan drug approved in that space, this will change the fiscal, the economic aspects. So that there are drugs approved for diabetic neuropathy, and these are the ones that have been approved for the painful aspect of small fiber neuropathy. Now, for muscle, this is where the big breakthroughs are coming, I think, in terms of some of the things. Enzyme replacement for Pompe's, that was, I always showed when I used to talk about this before 2006, and my slide said none, and now it says 2006. And then first for babies with Pompe's disease, floppy babies, uniformly fatal. This treatment keeps the babies alive, some of them, though it's proved to be of only temporizing, actually, because they develop antibodies, they have problems. The long-term results are nowhere near as encouraging as they were originally. Enzyme replacement then was moved into the adults, approved based on a small change in the 6-minute walk test, a very minor change in 6-minute walk test. And interestingly, although this is FDA approved, the majority of patients on whom it's been tried don't stay on the treatment. And so it's been used very little in the disease. Deflazacort. This is a corticosteroid that is thought to be perhaps less toxic than prednisone. I'm doing a big NIH study now comparing prednisone with deflazacort. So we will have data as to whether that's true. This paper is one, I was the author of the pivotal paper that got the drug approved. So let me tell you, when you're working in experimental therapeutics, if you do the pivotal paper and publish it, the number of people that want you to do things from pharma. No, when I used to say I have no conflicts of interest. That was a complaint, nothing else, because no one was interested in muscle disease back in the 90s and even the early 2000s. Now, once you get a pivotal study, they get very interested in you. So you're under pressure all the time to consult, to do this type of thing. So this is interesting because the study was done over 20 years ago, but buried by the drug company. They decided they didn't want to prove it. We resurrected the data eventually with the help of a company that was able to get the drug, and it's now approved for Duchenne dystrophy. I'll come back to talk a little bit more about that in a minute. Eteplirsen. Most of you know this has been front page news in the New York Times and in the Wall Street Journal, because this drug, I'm going to come back and talk about its cost, very high cost, had a trivial effect on dystrophin production in muscle. That was the basis of the approval. Duchenne dystrophy is a disease of boys, Jerry's kids. Everybody in the audience knows this disease, has seen it. One of the worst diseases of mankind. Dystrophin, totally deficient. Something like 1% of the dystrophin was replaced by this treatment. And there's been such controversy about whether that was a justified thing. The people left the FDA over this. It was a real storm of protest leading to lots of discussion, and it only works in 13% of patients. Though the company, Sarepta, has other exons being skipped, and as I took the slides out because I had too many, the next exon, exon 53, everything you would have liked them to show in exon 51 is present in the next. And that's will probably be approved later this year on the basis of good dystrophin expression, much better clinical data. So Sarepta was right. Jerry Mendell, who did the study, was right. Everything they said was true. It probably merited approval, but I'll come back and point out that it isn't that great a treatment. Now, this is the last one, is a drug. Also, I did the pivotal study, I have to tell you. I'm very proud of this. Started working on this disease in 1966. I'm sorry about that. Finally, a drug approved in 2016. And this is a pretty good treatment for periodic, both hypokalemic and hyperkalemic periodic paralysis. So I'm going to talk about now the prospects for new and better treatments. Because most FDA-approved treatments for neuromuscular disease are not really game changers. Pompe's disease, lots of problems. Lots of patients don't respond very well. So although they're approved, not that it was a major advance. We've got something to do. Docs taking care of patients love that, but it's not really what we want for the treatment. So this is my sort of categorization as you think about treatment. Ideally, we'd like to prevent the disease. And will just say in passing, I saw there's at least one or two stroke neurologists here. If you think about stroke, what we should be doing is preventing the disease. And when I gave a talk about treatment of all neurological diseases at my presidential talk at the American Academy of Neurology. I showed Ralph Sacco, who is a neurologist, president of the American Heart Association, talking about life's simple 7. And he pointed out that we know how to prevent stroke. Doctors know how to prevent stroke. Life's simple 7 are the things you do to prevent vascular disease. No smoking, control the blood sugar, control the blood pressure, control the diet, exercise, the typical things that lifestyle changes. And the question is, what percentage of people do the things that prevent stroke? And the answer is half of 1%. And as best I can see, if you talk to a large group of neurologists, it's very similar to that in that group too. We are not doing the right thing. So that is probably, of all the things I say today, that's probably the most important, because when we know how to prevent something, we should be doing it, and we're not. This is incredible if you think about it. And so I hold the neurology community guilty for this, because NINDS does not fund research to show how you change behavior of physicians and patients. Cancer Institute spends 30% of their budget on that, because if you can't get people to do the right things, what's the point of the research we're doing? So preventing the disease is the most important. That's my sermon on that. But let's go down to reversing disease, the Lazarus effect. If you had a patient with Lou Gehrig's disease, amyotrophic lateral sclerosis, and you gave them something, and they went from being in a wheelchair to getting up and walking and back to normal, how many patients would you need to show that? You'd say, maybe 1, you'd say, well, maybe the diagnosis is wrong. 2, you wouldn't take very many. So, but when you're thinking about stopping the disease, though, is also a cure, isn't it? Because we can make a diagnosis of any genetic disease before birth, can't we? So if you could stop the disease before it starts, that's the same as a cure. Unfortunately, most of the things we're trying to study in neurology to slow Alzheimer's disease. Then you get down to how do you decide if the disease is getting slower? You know, if you're, you know, I won't go around to the room to ask how many of you feel like you might just be getting Alzheimer's disease because your memory is slipping, but that's, you know, today it's okay, tomorrow it's not, the next day it's okay. You know, so if you start a treatment at the right time, I've always said, Greg's first rule of treatment is always start your treatment before the patient gets better. That's the medical profession has made a living for centuries with that rule. You know, you apply a leech, the patient feels better, that was the thing to do. So but slowing the disease is a hard thing to define, isn't it? Okay, so now let's just talk a little bit about this treatment approved for spinal muscular atrophy, because I think this is showing us light at the end of the tunnel of treating the neuromuscular diseases that are difficult to treat. This spinal muscular atrophy is an autosomal recessive disease. It is the most common fatal pediatric disease, most common fatal infant disease. Incidence is 1 in 10,000. 1 in 54 women or men are carriers, autosomal recessive. So very common disease. So this is an important problem. Causes babies that are floppy. It's caused by, it's a tricky genetics. I could spend 10 minutes explaining it to you, so I won't. Those of you who know it will know it, and the rest of you, I'll just have to take my word for it. There are 2 genes that do something very similar and make a protein called survival motor neuron protein. The 1 is the active one, 2 is abnormally spliced and so isn't active. In type 1, they have only 2, there's a little bit made by the second gene, just a little bit of SMN1. And so it's enough to make the disease quite variable. And so if there's a little more protein there, they don't die by age 20 months. But otherwise, all but 92% of the patients die by age 20 months. If they have a little bit more protein, they live longer, so they're milder, they're type 2, or they have a little more, they're milder, type 3, they're milder, even type 4 is even later in onset. So this second gene has a splice size variation that excludes exon 7, and you can use an ASO promotes the expression by modifying this SMN type 2. And that's how nusinersen works, and it has to be administered intrathecally and repeatedly for the babies, and several times for the older patients. So just to show you the babies, I'm not showing you the data that was reported in the New England Journal last November. Then a paper studying the later onset cases. Remarkably, most of us thought that if you lose your anterior horn cells, giving a treatment that might keep the remaining ones to survive would not do very much. But in fact, this study, which is quite remarkable and appeared 3 months ago, just showed, this is a Hammersmith measure, shows that in fact there was improvement in these patients, in the upper line. Even older patients, patients with the milder form of the disease, also improved. So this means that we'll be giving this treatment to older patients with SMA. Big study, very impressive results. And so it does work, but it has a relatively minor effect, but it's enough to impress people. And so older patients are starting to get it. Even patients in their 40s and 50s are starting to get this treatment. It's approved for older patients now. So this just shows the same thing in another measure. So what are the prospects for new and better treatments? Because this has to be given intrathecally. The babies get a slight amount of improvement relatively, but it keeps them alive. And so that's been important. They are staying alive, and so that's really a good treatment, relatively major advance, but in the same November issue of the New England Journal, Jerry Mendell, and I think even people who are not medical know about this treatment because it's been on the national news. The only reason I'm mentioning is because I think it shows us a path forward for almost any autosomal recessive disease in terms of the approach taken. This includes not just muscle disease, it's going to include other autosomal recessive diseases. So this is Jerry Mendell's study. He was the first author, Brian Casper, final author. These people had worked to show what the defect was. They then carried it into a single-dose gene therapy replacement. I might mention that when I recruited Howard Federoff to Rochester, the hope was that we would be doing just this within a few years of his arrival. It took longer, didn't it take, Howard? But you can see that it was worth the effort on your part and everybody's part, because Jerry built on the backs of many other people like Howard, who was doing work to get gene therapy into the clinic. What he did was an AAV9. Let me just go back and just tell you what he did. He took an adenovirus, it's called a gutted adenovirus, AAV9, and inserted the dystrophin gene into it. Well, the dystrophin gene is the largest gene in the human genome, so they actually inserted a microdystrophin gene in the Duchenne study. But the AAV situation is different. They were able to insert the SMN1 gene into the AAV vector and inject it a single injection, single dose gene replacement reported, and this shows the results. I'm not good on the dosimetry of how much they used, if they used low dose, and it's a log different for the second dose. They started with a low dose, and remarkably, even the low dose produced a benefit. And this shows, the bottom here shows the results of a historical study. There was excellent natural history data on spinal muscular atrophy done through a network of sites supported by NINDS. And it just shows that by age 20 months, only 8% of babies are still are able to breathe without a ventilator. So this means that when they started giving this treatment in low dose of gene therapy, the patients stayed off ventilators longer. So it worked, but then because it was safe except for some liver function abnormalities, they went and gave another 12 patients a higher dose. And the remarkable thing with the high dose is that using this measure, which is looking at the milestones of my pointer's not working, so I can't show you the dot where gene therapy, but you can see that on the left of the lines, each of the line is the timing of when the gene was given. The earlier they gave it, the better. If they gave it within the first couple of months, that the results were much better. And they showed the star as the last visit. There's now follow-up data that I'll just tell you about in a moment. So that only a single patient in the low dose eventually needed respiratory support. All the babies are still surviving, whereas this is a disease where all the babies are usually gone by 2 years. And so this is an amazing result. And the next slide shows the scales that they did. The low dose, just a little bit of improvement in 2 of the 3, whereas the early treated higher dose were, that would be good. Thank you. Thank you very much. So these are the low doses. You can see there's a little improvement. This is a Children's Hospital score about how much they move, and just shows there's this dramatic, abrupt, enormous increase. 60s normal. Some of these babies are getting up to normal. So that's the single dose gene therapy. Now, I was talking to Sean. He's seen the same thing I've seen very recently, and that Jerry was just giving grand rounds 3 weeks ago in Rochester, and he pointed out that those who've been treated less than 2 months are developing normally. And Jerry shows videos of the kids running up, pushing on the elevator. That's the one that's most impressive. And it's still going. This is now well over a year since the New England Journal. All subjects are maintaining their improvement. And newborn screening has started. And this is what you would think, that if once you know there's a potential for doing gene therapy, then the pressure is going to be on to make the diagnosis as early as possible. Jerry had experience doing newborn screening for Duchenne in Ohio, and it's been initiated for SMA, this disease, and it's been approved for the United States, but it'll take probably 2 or 3 years before it gets approved all over the country in actual progress. Company now is doing a multi-center study, not yet approved by the FDA, this treatment. They're doing a multi-center study. Avexis was doing this. They were just bought out, I think, 2 weeks ago. This is, I think, national news. Billions of dollars paid for Avexis, because it's obviously going to be a big thing. And I will tell you, the number of neurologists that Avexis hired that are in this field, and outstanding neurologists, have moved into the industry, because it's obvious that this is not the only treatment there that's going to be happening. So now, I'm not going to talk much about Duchenne dystrophy, except to say that when Jerry gave grand rounds, and Tassina saw this data too, they've done AAV9 with a microdystrophin. I started to mention this before, so I got a little ahead of myself. The microdystrophin gene is small enough to fit into the cassette, and so they've already done with the equivalent higher dose, because it proved to be safe in SMA in Duchenne. They have done 3 boys with Duchenne, and Jerry showed a video of the Duchenne boy running just a few months after giving the gene therapy. No Duchenne patient ever runs, not with Sarepta's treatment, not with the deflazacort we use. They do not run, running normally, and dystrophin expression in 70% of fibers, which is certainly going to be, one would guess that these will be mildly afflicted because it's not the full gene, but that this is extraordinary. And I think in the interest of time, I should point out, gene therapy, 2 big issues. Durability. One shot gene therapy so far seems to have worked, and there has been no abrogation of the response in the ensuing 4 years. So we do not know whether it's going to persist for the lifetime of the patient, but if it doesn't, there's a problem, because there's a limitation on giving this treatment. If somebody has antibodies, as some people do, to adenovirus, if they have antibodies, his treatment can't be used, and if they develop antibodies, that will preclude re-administration of this agent. So that means that there's a lot more to be learned, but this is unquestionably a game changer at this point. And really, I think the first of the treatments that are approved that don't have major problems in the long term. Now, this may have a major problem too. We don't know, but so far, the treatment has remained effective. And I would just say in amyotrophic lateral sclerosis, there's a strategy, an antisense oligo strategy, analogous to the eteplirsen strategy, analogous to what's being done in SMA, that holds promise for 10% of ALS. Although it's a remarkable situation, but I still don't think we understand fully. 10% of ALS is caused by this, including sporadic ALS, even though it's a genetic expansion, one of the expansion diseases. And so this is a disease. I think there's a reasonable likelihood that something will happen along the line of antisense oligo correction in this disease. And trials are actually starting by Ionis right now. So So I've already started to talk about this. In the last few minutes of my talk, I want to talk a little bit about problems with the multi-center trial and then talk about the issue of some of the problems with having orphan drug treatments. So when you're doing clinical trials in rare diseases, and all neuromuscular diseases that I'm talking about are rare diseases, of the 20,000 rare diseases, 20,000 rare diseases, most are neurological. So this is true of most of our diseases. Now, lots of common neurological diseases, but when you think about Alzheimer's disease, it's going to turn out to be, in all likelihood, lots of rare diseases. Certainly ALS is proving to be over 50 diseases. Parkinson's, I don't know how many genes are up to, ataxias, 20 plus. These are all going to be rare diseases, and the number of rare diseases is expanding. So large randomized placebo-controlled trials are hard to do in those patients, aren't they? Because you need large numbers of patients to do that. So you can do natural history controls, and I gave you an illustration of when using, a good natural history control, you can say babies with Pompe's all died. So if you start a treatment and they don't all die, that's a benefit. SMA, all died by age 2 years. Do you need a placebo group if that's true? The FDA has always said that you do, but they've actually published another paper I'm not going to show you that 70% of orphan drugs used in neurology, approved for all neurological diseases, did not have 2 randomized controlled trials. But N of 1 trials is also a way to go with rare diseases. And I'm very proud of this paper, although the drug is not FDA approved. We did do a big, randomized, large, 60-patient crossover study, and this is in myxillatine for myotonia. So you can do, this is a center from centers in 4 countries, got all the major referrals, so you can get patients, but it's a really challenge to do, a big challenge to do, and this was viewed as a triumph for our rare disease network. I will just say for those of you who are struggling to get NIH funding that this editorial appeared in the same month that our rare disease center was declined for refunding. So we got funded for 2 cycles, but that's all they wanted to fund us. Despite the triumph, we were the first and one of only 2 centers that were able to get a drug to approve as a big clinical trial successful. But there are other problems with the large multi-center clinical trial, and I just like to show this because you're talking about experimental therapeutics. This is a really interesting, problematic issue. Some of the things I'm going to just tell you about for a few minutes. One is the therapeutic misconception. I heard an ethicist from the NIH talk about this, and I hadn't really thought that much about it, but Frank McLean, I think his name is, gave a talk saying the multi-center clinical trial is unethical. And that is because if you put 50% of patients on placebo and 50% on drug, and then go back and ask the patients, what were you treated with? Over 90% of patients think they were on an active treatment, even though they were told that there's a 50-50 chance in the conformed consent that they would be on placebo. So and if you ask them what they thought, well, the doctor's doing this treatment. He wouldn't give me something that wasn't going to help me. So this is the notion that doctors are always doing something to help their patients. I suspect if we looked at that number now, it might be smaller because I think the medical profession is losing credibility fast. But this is one reason to argue for the N of 1 trial. And I'll point out that every patient gets the N of 1 trial, every patient gets placebo, every patient gets the treatment. So, but at the end, the large multicenter study also excludes comorbidity. You don't study atypical cases, and you often study a selected population. if your outcome, if you're doing a good big clinical trial, you always have a single or at most one or two primary outcome measures. But in many diseases, there are lots of different things that are troubling to a patient. And it also ignores subsets that benefit and subsets that actually worsen a big study. And so if you think about it, a randomized multi-center trial that improves 60% of patients will get rapid FDA approval. I actually have a slide I talk about. My drug is called Sevaway that cures stroke. And if 60% of patients would get a benefit, you would say, this is incredible. That's such a good treatment. However, we know that if you do a placebo-controlled trial, 30% of patients improve because of a placebo effect. So that means only 30% of patients are improving because of my drug Sevaway of stroke. This means that if you start the treatment, everybody's happy. The drug company's happy. Their drug's approved, fast-tracked, rapidly approved by the FDA. But the majority of patients, 70% out of the patients you give, 30% would have gotten better with placebo. 40% don't get better at all. So this then means that a success doesn't necessarily, a major success doesn't benefit many patients. So the N of 1 trial is the way to go. And I showed you that mexilotine trial. Got a paper we're hoping is going to be, it's under review, and it's been presented in abstract form, doing the same methodology we used with an N of 1 trial methodology, less than 1/3 the number of patients to do a trial with N of 1 methodology using Bayesian statistics. So for chronic diseases, in order to do the N of 1, you have to have a predictable course. It's a placebo-controlled trial. And I think the N of 1 for practicing physicians, I've always done N of 1 in practice with patients. You have a patient who gets an unexpected response, gone back and made up a placebo identical, had a pharmacy do that, got so sick of me doing that. But if you're going to leave a patient on a long-term treatment, you really want to know that it's not a placebo effect. So it's arguably a way essential for any treatment that doesn't have a Lazarus effect. And it is the best way to figure out a treatment for your individual patient. So then the last little thing I want to talk about is this. The unintended effects of the orphan drug product designation for rare neurological diseases. And so we pointed out that once a treatment like tetrabenazine for Huntington's disease, major improvement to the motor manifestations of Huntington's disease, very little effect on the behavioral abnormalities, did cost $500 once it got approved by the FDA. The company jacked up the price to 20 to 50 times the price. It could be imported by patients getting it from England or other countries where it was available. Once it was approved, no longer could do that. So this then meant that the drug was available, became unaffordable. And so the very person, Fred Marshall, one of my former trainees, who did the pivotal study, found that the drug was too expensive and he doesn't use it. He published the pivotal trial, doesn't use it. So that's the problem. And so that is the case for FDA-approved therapies. Mestinon doesn't do that much, but it's cheap. Eculizumab, which is working for drug-resistant myasthenia, $1 million. Very effective, $1 million a year, $1 million. Riluzole, once they become generic, Riluzole was very expensive. Now it's very cheap. There's a generic. Edavarone, it is very expensive I don't know, it's pretty expensive. Sometimes you can get insurance companies to pay for it, and I don't have time to talk about that but it's real money, whether the insurance company pays for it or not. And as you can see, with 20,000 plus rare diseases, we can't expect insurance to pay for everything that's coming along. Nusinersen, $750,000. really, really expensive. Pompei's, same price. It actually costs more than that because of the other things you have to do. Duchenne dystrophy, this drug that was available for about $500 to $1,000 a year from Mexico, Japan, Canada, or Europe, now costs $90,000 a year. That's my drug. So I'm getting nothing. So we did the study. Eteplirsen, same order of magnitude. And that was the thing that people complained about. My treatment for periodic paralysis, too expensive. One of my prize patients dramatically benefited, won't take it because it's too expensive. So this is So this was a paper that came out in JAMA, and this was about the Eteplirsen experience. Then Aaron Kesselheimer, who's an attorney at Harvard, also a physician, just decried this and thought it was a crime. One, they thought it was wrong that it got approved, but I think that was right that it got approved. But it's still wrong that they charged so much. Just to point out that, so as you know, President Trump said he was going to fix this. And as you know, you probably saw the headline in the Wall Street Journal just 5 weeks ago, 6 weeks ago, saying that when Trump made his proposal, the drug companies breathed a sigh of relief. He did nothing nothing, essentially nothing. And the stock market for the drug company stocks went through the roof after he announced his policy. Nothing of substance. There are lots of things that can be done. The United States is the only country that does not control drug prices. England is not as good as Japan, where it's 10%. You get cost plus 10%. So you can make a profit. Every other country in the world who's developed a policy has limited. The United States doesn't do it. I think, and actually I may yet write a paper about it. I think that if we ask subjects who are part of a clinical trial to, as part of the consent form, to approve the fact that the drug is going to be unavailable, people would not be able to get them to sign a consent for treatment. And so I think there is a way to address this other than stopping the pharmaceutical industry buying the votes of everybody from the White House to everybody on Capitol Hill. But as you can tell, we allow direct-to-consumer advertising of drugs, only country in the world that permits that. Again, same reason. The pharmaceutical multi-billion-dollar contribution to our political system. But I think the ethical issue might be able to get this under control. But that will take time. Okay, so there are diseases without FDA-approved treatments. And this is a problem because not only does it limit my ability to tell you about treatments if they're not FDA approved or need to caution you, it's off-label treatment, it also means that it's hard to develop standardized guidelines for FDA approved treatment. It's done, but it's a bit difficult because the insurance companies can deny them. So you put doctors in an awkward position if you cannot develop guidelines. So neurologists, I think neurology is one of the worst specialties for the lack of a standardized way of treating almost everything except stroke, almost every other disease. But now these FDA-approved treatments, we're going to have guidelines, and so that helps. So that's one reason that it's a problem, because everybody treats polymyositis, dermatomyositis differently. As I've already said, the recessive diseases already, there's gene therapy for one of the limb girdles, not approved, but there will be many others. Charcot-Marie-Tooth disease, you'll see there'll be many others. All the other diseases, I think we're going to see a major advance. The only problem is we've got to control the prices. So the last thing I want to just talk about quickly in the last 2 or 3 minutes is our fellowship program in training in experimental therapeutics. Mark Mapstone is one of our trainees. We train neurologists. We also train neuropsychologists. We've had some outstanding neuropsychologists. Mark is arguably the best of breed. He was absolutely terrific and has done incredible work and a real leader in Alzheimer's disease research. But we've trained people for many, many diseases. It's a 2 to 3 year fellowship. I'm really basically talking to the one person going off to do neuromuscular training. So in the audience, it's mentored by a neurologist, a statistician, a neuroscientist, multiple. I tell you the number of options that the people have gone through this. One of the audience brother actually went into this program, and I can't tell you how many people wanted him to go work with them. Absolutely outstanding. And they've been so successful, it's just incredible. This was a NINDS, and almost all of our fellows who've needed debt repayment have been successful in getting loan repayment. It's just been easy to do. So we have trained over 80 people now in all of these areas. We have trained a few statisticians. Over 90% are in academic positions, and most of the others are in industry leadership positions in industry. So, and we published about our program about 6 years ago. So finally, since 1995, many conclusions have received FDA approval. Almost all are approved are orphan products and costly until their patent protection expires. None of the approved treatments are what I would say are game-changing, but I think we do have game-changing treatments on the horizon in terms of gene therapy. All of the drugs are exceedingly expensive until they go off patent protection. And the last point I told you about Duchenne and other recessive diseases. So with that, I'll stop and acknowledge the fact that I'm not the only one who's done my work. Muscle Study Group, Tosin, you're probably in that picture some way. This is a group of investigators from many countries around the world who have banded together to do clinical trials in these diseases. And so I think you can see Rick Barron now I started this, ran it for almost 20 years, and Rick Barron is now running it. It's a great group. If people present an abstract to our annual meeting, we usually pay their way. The meeting is going to be in Oxford in a little over 3 months. So I don't know if anybody from Irvine other than Tosin is going, but it's been a great group, and these are the people that were part of the periodic paralysis treatment and are working with on other things. So thank you very much.
Thank you, Birch. I unfortunately had to leave early from that MSG meeting because I had to finalize my NeuroNext grant, which luckily got funded, so it was definitely worth it. But that's why I'm not in the picture. But Namita Goyal, Marie Wenzel, and Veena were there, and they are also going to Oxford this year as well. As a token of appreciation for your talk, I'd like to present you with this plaque, which identifies you as a Van Noort lecturer with a picture of Stan on it.
Thank you so much. I know this guy that's on the picture. He looks just like he did when he was telling me, Griggs, that's artifact on the EEG. Thank you very much.
Thank you. I think we have time for maybe a couple of quick questions for Dr. Griggs.
Can I just say, because we're recording tonight, if you have a question, I'm going to bring over a microphone, okay?
Dr. Bota?
Wonderful talk. Thank you so much for this presentation. What I would like to find out from you, you talked a lot about what in oncology we talk financial toxicity for those drugs that you are developing.
Sorry, say it again.
Financial toxicity.
Yes, financial
but
toxicity.
Going
absolutely.
to the next step, what is your methodology of calculating the inflection point? What is the drug worthwhile pricing? Years of disability, years of life saved? Because, when we look at 50,000 or 500,000 or $1 million, they're very different amounts. So how do you make a decision for yourself or on your mind where this drug has passed the inflection point and is worthwhile financially, or it's a drug that is overpriced, not based on the production costs, not based on research and development, but based on year gained or disability saved?
So, yeah, I have a microphone. I think Brad, you've got me on. Yeah. So this is a really important question, and in fact, there's a family practitioner, Stephen Wolf, who's talked about the break-even point of new treatments versus old treatments. A cheap old treatment, often given to a larger number of people, and that's my point about prevention. If we would spend money on prevention and figuring out how to change behavior, because you can change behavior. This is something that can be done. It's been shown in oncology. You can change physicians, you can change patient behavior. It takes work, it takes research, and so we should be investing in that. So I agree with the implications of your question, that we should be investing in things that improve health overall. At the same time, America is a rich country, and we should be able to figure out ways to afford treatments that are truly expensive. But you're also correct in that the pricing of drugs has, in my case, these are both drugs. I got the NIH grant that paid for the development of my treatment for periodic paralysis. And so what's the company doing, charging, tens of thousands of dollars of treatment? It's a boardroom decision. Same is true for deflazacort. And the Wall Street Journal wrote about that very treatment and tried to corner me and say I was getting rich from it. I'm not getting any payment from it, but sort of a complaint, not a but it's such an important question. I will say that I do give the Strongbridge. I do continue to consult for Strongbridge. I am on their speakers bureau, and they are scrupulously attentive to making sure that what I say when I speak for them is consistent with what's FDA approved. They're starting a registry. They've got a registry. They're keeping track of their patients. They've 200 patients have been treated. They actually will give the drug free to patients to get started on treatment. So if they benefit, then they go to the insurance company and say, look, they have evidence this is a treatment that's working. So to some extent, I feel like they've been somewhat responsible, and they're sort of looking at, because of how this drug plays out in practice is obviously critical to knowing, how does it work, what patients does it work in, and so we are anticipating getting information on that, because not all patients respond. The ones that do get actually a game-changing benefit. Some, they become asymptomatic. People who are totally disabled, you get out of a wheelchair, and so it is remarkable. So, but the company is trying to address it, but again, getting an insurance company to pay the money is only kicking the can down the road in terms of the cost of new drugs. The insurance industry is not going to be able to afford all the treatments that are going to be available within a matter of very, very few years.
In your first slide, I saw that you listed Stealth, the company. Is that the Stealth Therapeutics?
Say it again.
Stealth.
Stealth? Yeah, Stealth. I consult for them, and they've asked my opinion twice for a 2-hour thing, and because I've been experiencing clinical trials, they're working in mitochondrial myopathies.
Exactly.
They have clinical trials and very encouraging preliminary data, phase 1, and they have a big trial in phase 2. I don't know the results, but they have asked me for advice about how they do their trial on that, because they're probably going to do another trial. So I do not know much more about that, and I'm not at liberty to say anything more about it.
So they are using their compounds on the neuromuscular?
They're doing treatment trial in mitochondrial myopathy.
So Bandivia,
yes.
the compound that is being used. Okay, thank you.
Yeah.
Wonderful talk, thank you. So my question pertains to your comment about none of the drugs
I'm coming closer to
none of the drugs were game-changing, but they are game-changing in spinal muscular atrophy and Pompe disease, like infantile Pompe disease.
So if you look at I may be overstating the case, but what I know is that the gene therapy area in Pompe is moving is really pushing, because the enzyme replacement, which is the one that is proved, does very little for the later onset cases, very little. That, everyone agrees on that. And in the babies, they develop a lot of time immunoreactivity, and so that relatively few of the long-term treated patients are continuing to do as well as it looked like they would do. So yes, of some babies, and so my treatment for periodic paralysis is a game changer in a small proportion of patients, possibly in a small proportion of babies, because the long-term experience has not yet been reported. But in fact, most of the cases have sort of progressive difficulties once they are treated. You may be treating patients, I don't know, with acid maltase. I have essentially no experience with treatment of babies with acid maltase.
It's disappointing in adults.
It's
I agree.
disappointing that what looked like it would be sort of we didn't know how long it would last, and it's looking like there are ever increasing problems.
And the good thing is that other companies are stepping up to the plate and coming up with novel treatments.
Yeah.
So my question also pertains to gene therapy. So it's really staggering, the results from the spinal muscular atrophy, and it's probably just a matter of time where the treatment's going to be so cheap that it would be a no-brainer, that would be the way to go.
Eventually, but that's an interesting question. Gene therapy if gene therapy gets approved, which it probably will within a year, I would imagine a year, 2 or 3 years, then at some point there'll be other companies that enter the field, and it will become a generic treatment. Gene therapy is probably going to be a little harder to get into the field, I would think, wouldn't you, Howard? You have to know Jerry Mendell to know just exactly how big a challenge it was to get as far as he got with this. Been working on it for 45 years. And he had to create a manufacturing facility for it. But you're right, I think gene therapy will eventually become affordable. So I think that's probably true. Yeah, but each new treatment it's going to take decades before that's widely available. So thank you for your question, though.
So Virginia, just to put a perspective on that thing, so what the companies that are in the gene therapy field, especially SMA, the question they are posing is, what's the cost of a cure?
Yeah.
And it's anticipated that they probably will be over $1 million, probably in the 3 to 4 million range, but we don't know what the actual cost is going to be. But it's a challenge.
And one of the problems with that is that often, like in England, they'll have fundraising campaigns to raise the 3 or 4 million. So you have much of society's money going to support tear-jerking things, and so it's sort of distorting. And so this is one of the reasons why I think that it would be good if there are a lot of things that Congress ought to behave itself in, because I think getting a cost-plus policy would be more sensible. Yeah.
There is an interest part of one very large foundation represents a collection of rare.
Start again, Howard.
Yeah, so there is a discussion right now. There's a large foundation that represents a collection of smaller foundations, each of which has its own orphan. And all of them are amenable to gene therapy, principally through adeno-associated virus. And so there's a discussion about whether they would raise the money to basically fully underwrite the costs of the therapy, which would not be sold at a cost-plus basis, but just as covering the cost for the manufacturing, which I think is going to be very interesting because it addresses the socially responsible comment that you made earlier. But a lot of the other gene therapy companies are likely not to want to go in that direction unless they can secure price standards, like take Spark Therapeutics, which are going to be very high and I think are going to be remarkably pushed back from the standpoint of payers. But you're right, the total cost of a cure is something that is entered into the discussion, but I think the foundations need to win out because it's impossible to imagine that our commercial insurers and our federal insurers are going to pay for all of these therapies,
Yeah.
even though they are game changers.
So one of the things I'm impressed in England, they will not give grants to fund trials unless there's a way forward to make the treatment affordable. And that's, you know, that would be a way to deal with it. There are steps that can be taken. We haven't gotten there quite yet. So thank you all for your attention.